All right, team, let's begin Chapter 6, the human body. As I talked about earlier, the human body, anatomy and physiology, medical terminology, common language, right? Universal language that all medical providers are going to use. So we are going to treat this as a foundation in which we're going to build upon going throughout the rest of the semester. This is a difficult topic. We have entire college classes, semesters long, just on anatomy, just on physiology, just on pathophysiology. So we're going to condense that all into one little 4-hour lecture. So sounds good? But like I talked about, moving forward as we go through each different types of emergencies with different body systems, we're going to do an intro to that body system, so it's kind of like a review, but then we're going to go a little deeper, okay, a little deeper. As I talked about, the national standards, every medical provider needs to have that working knowledge of human anatomy and physiology. You as an EMT, I want you to have a working knowledge, because I don't want you just to do something because it's what the protocol says. I want you to do something because it's going to have an impact on the patient's body, and you understand why and how. Okay, that's the key concept and takeaway. Again, fundamental knowledge, we're going to kind of skip through this because we don't have a whole lot of time today to get through all of this. Good. So what are we going to really kind of cover today? Anatomy, physiology, and pathophysiology. When we're talking about anatomy, we're more talking about identifying structures, right? Identify different bones, muscles, organs, tissues, and cells, right? With physiology, we want to know how something works, right? So for the cardiovascular system, for example, yeah, you need to be able to identify the heart, the chambers of the heart. You need to identify arteries and veins and components of blood. But physiology-wise, I want to know why the cardiovascular system does what it does. What's its purpose, right? And essentially, it's going to be to, transport oxygen to different tissues, going to transport waste products to be excreted from the body. We're going to kind of dive into all of that with all the different body systems. Pathophysiology, we're referencing how does a disease process impact the physiology of the human body. So if someone has what we call a myocardial infarction, where you have death of heart muscle, how does that impact the physiology? Okay, so that's what we're going to dive in today. We kind of hit on this in the last chapter, topographic anatomy. Okay. Applies to a body in anatomic position. So once again, we're talking about a person is doing what? How are they presenting to us?
Face forward, palms up.
Good. They're standing upright, feet shoulder width apart, hands down at their side, palms facing up. Perfect. That is anatomic position, anatomical position. It's our reference point for every patient you're going to have. And every medical provider has the same reference point. That's going to limit the confusion when you're describing injuries of the patient and how they're kind of describing their pain and how it radiates. Planes of the body. Here it is. These are imaginary straight lines that divide the body. Okay. Again, primarily this is going to be in terms of the context of EMT, more so diagnostic imaging. So you have an MRI, an X-ray. You're looking at the body from different viewpoints. That's more or less how you're going to use these terminology. So the three main areas. You have the coronal or frontal, okay, plane. Divides the body into front and back halves. Okay, so that's going to cut the body this way from the side. So a front and so an anterior and posterior section. That's the imaginary. So again, that's coronal or the frontal plane. And there's a nice image on the next slide to kind of visually give you a representation of it. Sagittal or the lateral plane divides the body into left and right. Okay, just left and right. The mid-sagittal or midline divides the body into equal left and right halves. Okay, so what does that mean? So sagittal, there are various sagittal planes. Okay, mid-sagittal is directly down the center. Okay, so you can have a plane where you're just kind of looking at the shoulder. Okay, so you're cutting from an anterior to or superior to inferior portion, so straight line, cutting the arm off, looking at the shoulder. So that's a sagittal plane. Okay, it's like a parasagittal plane. If we're dividing it directly down the middle into equal right and left halves of the body, we're going to call that mid-sagittal. Okay, mid-sagittal, or as we talked about, the midline. Transverse plane divides the body into a superior and inferior, so top and bottom. So it's going to cut you right at the waist. Now, it's not just at the waist. It could be at any portion of the body. Okay. So you're slicing the body in half, and you're kind of looking from that aerial perspective downwards. So here we have some imagery, and that's the imaginary lines that are dividing the body into different planes of existence, so to speak. Make sense? Any questions there? Excellent, excellent. Cells to systems. Now, again, the body is a very complex entity. We don't have the time to actually go so in depth in all of these concepts of the body, because again, full-on semester classes are dedicated just to cells, dedicated just to skeletal. It's just so much to kind of cover. So we're going to try to focus more on the impact that this knowledge will have as an EMT in the pre-hospital setting, but just know there's a lot more to learn. But it is a nice foundation in which you're building, okay? Because if you decide to go a different route later on in life, nursing, doctor, paramedic, this is a great foundation that you're going to just add more knowledge to. So let's kind of break it down. A cell. So the cell is a foundation of the human body, okay? When you have a bunch of cells that come together and have a common function, we call that a tissue. When we have a bunch of tissues that come together and have a similar function, we call an organ. And then when we have a group of organs with similar functions, we call that a body system. A body system. So that is the simplest breakdown, okay, of your body, of your entire existence. Cells all the way to body systems. So so these guys right here, like if you look at me right here, these are like sound reducing panels, and it's very eerie when I'm talking right here. It sounds like my voice is not traveling at all. I don't like it. I don't like it. All right, so the skeletal system. This is going to be one of the most important that you're going to need as an EMT. The skeletal system, muscular, there's a lot. Obviously, we're going to go over all the body systems. But when we're talking about traumas, injuries to the body, what is commonly impacted is the skeletal system. So let's do a breakdown. The skeleton gives us our recognizable human form. Okay, an adult skeleton is composed of 206 bones. You can break it down. This is fine. The axial skeleton, the appendicular skeleton, and then the pelvis. The axial skeleton is referencing the skull, the vertebral column, the thorax. Your appendicular is more going to be your arms and legs. You could throw, it depends on the textbook, but you could throw in your scapula and your pelvis into those as well. But it really depends on which textbook. Some throw the scapula and the pelvis into the axial. Doesn't have that big of an impact on what you do. Axial foundation in which the arms and legs are attached. Again, skull, facial bones, thoracic cage, vertebral column. As we talked about in the last chapter, joints. Wherever you have two bones that come in contact, it creates a joint. Consists of the ends of the bones and the connecting and supporting tissues. Now, not all joints are created equally. Okay, the whole point of a joint is to either have stability or movement. Okay, stability or movement. When we're talking about the most common being, at least the most common that you're going to see, is the ball and socket joints and the hinge joints. Okay, ball and socket and hinge. Your most common ball and socket will be your shoulders and your hips. and that allows for different degrees of freedom or ranges of motion. Typically, it has the most movability, okay? So you can do flexion, you can do extension, circumduction, internal, external rotation, abduction, adduction, all of it. Now, with that freedom of movement, it comes at a cost, and that cost is stability. So those are going to be the most unstable joints in the body because it has the most movement. So the less movement at a joint has more stability, okay? For example, the sutures joint in your skull that connect all the skull cap parts, you know, your temporal, frontal, parietal, occiput. Those are joints because they're different bones that come together, but they're fused together, okay? And that makes a suture joint. So there's 0 degrees of freedom. They cannot move at all, but they have the most stability. Some examples of a hinge joint. You got your elbow, your knee, and technically, at least how they're going to kind of describe it here, is that a hinge joint can only do more or less 2 motions, and that's going to be flexion and extension. There are some accessory movements that kind of occur. What other movement can occur at the elbow? Let's see if anyone knows. Anyone took anatomy and phys, more just anatomy. Yes.
Hyperextension?
That's still just a type of extension. Yeah, if you have a lot of laxity in your elbow, you can hyperextend. So it goes beyond the normal movement patterns. But what about this motion? What about this motion? Yeah, pronation, supination. Pronation, supination. That's technically at the elbow, but there are some accessory movements going on in there as well. You technically can do an internal, external rotation at the knee. You have to be like in a seated position, but it's not very common. It's not a common movement pattern. Yeah. Perfect. There's a lot more other joints, but we're not going to get too in depth. These are going to be the ones that are more commonly injured. And you have higher chances of injury with the more movement patterns. The connective tissues that we're mainly talking about are connective tissues that connect bone to bone. What are those? What are those?
Ligaments.
Ligaments. So ligaments are fibrous connective tissue that connect bone to bone. So they're going to help stabilize it, right? Because again, you just have 2 bones that just meet, so there has to be something that keeps them together. Ligaments, that is their job. Now, there are other components that help secure it in place. You have, depending on the type of joint, you might have a joint capsule, specifically in our synovial joints. Your tendons, okay, and tendons connect muscles to bones. And that's going to allow for movement, but it also provides some stability, okay, some stability. Here we have our skull. Again, it's made of, the cranium itself is made up of 4 bones. Again, that's going to be the top portion. You have the frontal bone, that's right in the forehead. You have the temporal bone, which is going to be bilateral. You have the parietal, which is going to be more on the sides of the head and the top, and then the occiput, which is going to be in the back of the skull. Then you have 14 facial bones. Now, in class, you have to memorize these bones, okay, especially in lab. When we're doing our trauma assessment, our head-to-toe detailed physical exam, I do expect you to tell me what bone you are palpating. Okay, remember palpating means to touch, because I want to know if the patient is experiencing any pain at those areas, if there's any instability, any crepitus. I need you to know what bone you're touching so you have a good idea of what bone is injured. Now, you can't make a diagnosis. Okay, that's one thing about being an EMT and most medical providers. You're not allowed to make a diagnosis. That means you can't definitively tell the patient, hey, you have a fracture, which is a break, to your femur. You can't tell. Now, can you say, hey, my clinical diagnosis is that you have this? Yes. All the signs and symptoms point to you having this, but I'm not a doctor. You know, I don't have an X-ray machine, MRI machine in my eyes. So we got to save that for the hospital. Again, you can have what's called a index of suspicion, and that's kind of like how you're going to base a lot of your treatment on is just, hey, patient has X, Y, and Z, that everything is leading towards this pathology or this injury. What is the best way to treat it? Okay, and you have to just work with what you have. You have really limited resources out in the field to diagnose and get a definitive answer. So you just work with what you have, which is typically the patient information that you get and the vital signs. So our facial bones, some of the main ones, again, you have your nasal bones, your zygomatics, which are going to be your cheekbones, your maxilla, which is your upper jaw, the mandible, which is the lower movable jaw. You have more internal bones, but I'm not going to have you memorize, okay? When you take an anatomy class, they'll legit have just a random bone chilling on the desk, and they're like, hey, what is this bone? And then they're going to take a step forward. Hey, is this the right or the left? Yes. So you have to know every part of a bone, not just like, oh, this is a humerus. No, you got to know every portion of that bone. We don't have time to do that, unfortunately. It'd be fun, though. But when you take an anatomy class, that's what you're going to be doing. So for me, the biggest ones I want are the ones that you can touch. Okay. So the nasal bones, the zygomatics, the maxilla, the mandible, perfect. All the cranium ones, the frontal, parietal, temporal, occiput, know all of those. The foramen magnum, okay? A foramen essentially is just an opening. It's just like a term meaning an opening. This one specifically is at the base of the skull, okay? Now what goes in there?
The spine.
The spine, okay? Now more importantly, what is one of the key features of bones? Like, what's their purpose?
Structure and protection.
Protection. That's the one I'm looking for, protection. So you have the vertebral column that goes all up in there, but again, the vertebral column is just a bunch of bones that are good. Inside is the spinal cord, okay? And that attaches to the brain, and that is how your brain can send and receive transmissions throughout the body, okay? That hole is where it goes through and connects to the brain. Okay, I've seen it on a bajillion tests. They always ask about that foramen magnum. So I want to make sure you understand that is the hole, the opening at the base of the skull in which the spinal cord attaches to the brain. Your spinal column or vertebral column. It runs the entire axial skeleton from your skull all the way down. It has 5 divisions, okay? So starting superior to inferior, so starting at the top and going down. You have the cervical, thoracic, lumbar, sacral, and coccyx. Now in each division, it's made of individual vertebrae, or vertebra, if you will. The cervical vertebrae, there are 7. There are 12 thoracic. There are 5 lumbar. There are 5 fused together sacral vertebrae. And there are 4 coccyx vertebrae that are also fused together. You need to have that memorized. Okay? You need to have that memorized. So 7, 12, 5, 5, 4. It's going to sound ridiculous right now. But the way I learned it, or at least memorized it, is that you have breakfast at 7, you have lunch at 12, you have dinner at 5, and then you have a late night snack at 4. That last one I just added. There's just the last one's 4. That's all you got. So 7, 12, 5, 5, 4. Perfect. And it's made of 33 individual vertebrae. Question.
Is there any sections most likely to be damaged?
All can be damaged. The sacral is probably the least because it is fused together. So it's like a solid brick of bone. It kind of depends. The bone itself, not really. You're caring more about the spinal cord damage that could happen. In between each of these vertebrae, there's an intervertebral disc that's commonly damaged. There's a lot of compression of nerves because at each site, I don't know if you can see it on your guys' left, you have nerves that are coming out of the vertebrae. So those are damaged a lot more than the actual bone itself. It takes a lot of force to damage a bone. Okay, a lot of force. And we'll go through like what's called a stress strain curve to kind of understand that concept. Now, what do you care most about? The cervical vertebrae are by far the most precious, if you will, because if that is damaged and the spinal cord up to a certain point is damaged, higher chance of becoming a quadriplegic, losing all functions of your system, your body, your muscles, things of that nature. Your thorax. So this is going to be your chest, right? Let's talk about the different bones here. It is composed of your clavicles. You have your sternum, 12 pairs of ribs. And again, they're going to consider the scapula as part of the appendicular, so we'll talk about that in a minute. So your ribs, you have 12 pairs. Okay, they are bilateral. Okay, you have 10 pairs that are true, 2 pairs that are false, or what we call floating ribs. Okay, the 10 pair that we consider true ribs are connected to the sternum. Okay, the sternum is that bone right in the middle of the chest. It is connected by cartilage. It is connected by cartilage. The 2 at the bottom, 11 and 12, it does have hyaline cartilage on the ends of it, but it does not connect to the sternum. So they're just floating there, just kind of big chilling. Inside of the chest cavity, you have organs. You have very important items that need to be protected. You have your heart, lungs, esophagus, and great vessels like your aorta. Now, in terms of the sternum, it is comprised of 3 different parts. Okay, you have the very superior portion. We call that the manubrium. The manubrium. Then you have what's called the body of the sternum. And at the most inferior portion, you have a little cartilaginous tip, and we call that the xiphoid process. Everyone's good? Everyone's checking it out? All right, all right. The appendicular skeleton, arms, legs, connecting points, and the pelvis. Again, joints, upper extremities, pelvis, lower extremities. Let's break it down. The upper extremity extends from the pectoral girdle to the fingertips. The pectoral girdle kind of references the clavicle, the scapula, and the humerus all together. Your whole upper extremity is going to consist of, again, those components, the humerus, the radius, ulna, carpals, metacarpals, and phalanges. Let's begin. All right, the clavicle. The clavicle, also known, you're probably more familiar with the term collarbone. Those are little S-shaped bones right in the upper chest. It connects both to the sternum and to the scapula. The sternum and the scapula. Now again, all joints in the body have specific names, like special names. I'm not expecting you to know all of them, but I do want you to know the big ones. Here we have 3 specific joints I want you to memorize. First, you have the joint between the sternum and the clavicle. It is called the sternoclavicular joint. A lot of the joints, they're going to reference the 2 bones that are being connected. Okay, so stern referencing sternum, O combining vowel, clavicular referencing clavicle, sternoclavicular joint. Now we have the clavicle that goes to the scapula or scapulae. There are different parts of the scapula. The part in which the clavicle attaches to the scapula is the acromion process. Okay? So this one is called the acromioclavicular joint, often referred to as the AC joint. Then we have the humerus. Okay, the humerus is the long bone in the upper arm. That connects to the glenoid fossa of the scapula. So this one is called the glenohumeral joint, also referred to as the GH joint. Perfect. Any questions there? Good. Excellent. Excellent. Very good. Very good. Humerus is the supporting bone. Sure, why not? Forearm consists of the radius and ulna. In directional terms, where is the radius located? Is it more lateral or is it more medial? Good. It's more lateral. Okay. We're thinking anatomical position. We're thinking away from the midline, so it's more lateral. The ulna, more medial, okay? So you think thumb side, lateral, pinky side, medial. Perfect. That's fine. The hand and wrist, okay? So going more distal, away from the point of attachment, we make our way to the wrist, okay? See if this is going to work. I don't think it's going to work. So I have to like point it that way for it to work. That's fine. So we have the wrist bones. As you can see, there are a bunch of individual bones. Okay. We group them together, and we're going to call them the carpals. The carpals. You do not need to memorize each one, because you have like the hamate, capitate, lunate, triquetrum, yeah, you don't need to know all of those yet. Once you go like paramedic, nursing, athletic training, then boom, knock it all out. But if you just call them the carpals, perfect, I'll take it. Going more distal, we're going to go to the hand bones. Okay, hand bones. We're going to call those metacarpals. Metacarpals. So those are the long hand bones right here, right there, there, and there. Just that, those long bones. Now it is important to know how to describe each one. And we're going to do it by numbers. The thumb counts as your first digit, if you will. Index second, long third, fourth, and fifth. I do not like you saying, oh, the ring finger or the small finger. Yeah, we don't, no, we're going to do, this is the first metacarpal of the, which hand are we looking at?
Right.
Okay. Second metacarpal of the right hand, third, fourth, and fifth. Okay. Going more distal, we have phalanges. Okay. The fingers and the toes have a common name, and we're just going to the grouping phalanges. Okay. Same concept, however, you have a first, second, third, fourth, and fifth. So this is your first phalanx. Okay, so that's going to be the singular of phalanges. Second, third, fourth, and fifth. As you see, there are 2 bones here. There are 3 bones, 3 bones, 3 bones, 3 bones. What do you think we're going to call this bone right there? So it's still the first phalanx, but we're going to call that the proximal phalanx, distal phalanx. First proximal phalanx, first distal phalanx. When we go to the end, and that's the thumb and the big toe only have 2 bones. The other fingers and toes have 3. So we're going to have a proximal, middle, distal. Proximal, middle, distal. Proximal, middle, distal. In terms of how you're going to document that, you wouldn't. You're not going to go that in depth because, again, you can't diagnose. If you say they have a fracture to the distal phalanx, first phalanx, that is a diagnosis. Okay. Good. Any questions there? I didn't think so. You guys are doing so good. Pelvis, moving down. The pelvic girdle consists of 2 coxae, which are going to be the hip bones, a sacrum and a coccyx. okay? But those coccyx have 3 different bones fused together. You have the ischium, ilium, and the pubis, okay? Hard to tell on this one. There's some other better diagrams that kind of color codes, like, oh, it's all fused together, so it's like one singular block of bone. But it's separated. So back here is the sacrum, which is one of the lower divisions of the spine, connected to the hip bone. So you have the ilium, the ischium, and then the pubis down here, all together, okay? Now, there's 2 of them, so they are bilateral. In between, you have a little pad. This is the cartilaginous pad. This is the pubic symphysis. Okay, perfect. What else do I want to say? A part of it, you have the acetabellum, which is one of the attachment points for the head of the femur. Good, good, good. Here you have 2 great vessels. You have the descending aorta. The aorta is bringing oxygenated blood to the lower body. Then you have the inferior vena cava, which we're going to talk about. That's bringing deoxygenated blood from the lower body back to the heart. Moving, again, more posterior, not posterior, inferior. With the femur. The femur is the largest, strongest bone in your body. It's your thigh bone, okay? It's your thigh bone. Even though it is like the strongest, it's still very common to injure it, okay? But typically it takes a greater amount of force. So we're talking about car crashes, some type of sports collision, something that's very high velocity, high impact, high forces. Connects into the acetabellum, again, which is a part of the pelvic girdle, by a ball and socket joint. The greater and lesser trochanter of that femur, those are just like little protrusions, if you will, from the bone. And those are just attachment points for some of the larger muscles, which we'll talk about in a little bit. Going down, we have our knee joint, if you will. Talofemoral joint? Yeah. So the joint itself, tibiofemoral? Oh, I'm drawing a blank on the name. Knee joint's fine. Knee joint's fine. But it connects the femur to the tibia. Okay? Femur to the tibia. Okay? You have a little oddly shaped, irregular shaped bone that's more anterior. That is the patella, or the kneecap. Okay? The kneecap is very important for walking, because it's kind of like a fulcrum, a lever, if you will. You have the quadriceps tendon that connects to it, and then you have a patellar tendon that connects on the more inferior portion, and that is vital to have a smooth working knee, so it's not all clunky. What artery is behind the knee? It's a little higher. It goes into it, but yeah. What else? Oh, yes, popliteal. Popliteal. And again, for us, that's just going to be a auscultation site when we do a thigh blood pressure cuff, or blood pressure rather. Going more inferior, we're going down to the lower leg. You have the tibia, which is often referred to as the shin bone. That is going to be more anterior and medial. It's the larger of the lower leg. The fibula, very skinny looking bone. It's going to be more lateral. Okay, more lateral. Now, I do want you to know what we call the medial malleolus and the lateral malleolus. Okay, so when you look at your ankle, you have those 2 big bony protrusions on the side of your ankle. Which one's which? What do you think that is, actually? So those are the distal ends of your lower leg bones. So the further apart. So on the medial aspect, it's going to be the tibia. Okay, so it's the distal part of the tibia. On the lateral side, it's the distal part of the fibula. Okay, but we call those the lateral and medial malleolus. Excellent, excellent. Another one I want you to know is at the top of the tibia, more superior, it's the attachment point for the patellar tendon, and that's the tibial tuberosity. The tibial tuberosity. So if you feel the top of your shin, you have kind of like a little bump. That is your tibial tuberosity. Ankle. So your ankle is really made up of two joints. You have the talocrural joint and the subtalar joint. They both have different movement patterns. Again, the joint's all about movement. The talocrural joint allows for flexion and extension of the foot, but we don't call it flexion and extension. Okay? We have special names when we're talking about the talocrural joint. We have dorsiflexion, plantar flexion. Dorsiflexion, plantar flexion. Okay? So dorsiflexion is referencing essentially your foot is going upwards. Okay? So you have the dorsal part of the foot goes up. Boop. You could you could reference it as being a flexing, see, dorsiflexion. But then you have plantar flexion, which is down. You're planting your foot down. So plantar flexion, dorsiflexion. That's the proper term we're going to use for the ankle. Now, for the subtalar joint, which is right below it, that can allow inversion and eversion. Okay, so it allows your foot to rock front or side to side, more or less, side to side. You ever rolled your ankle? Inversion. Okay, opposite direction, eversion. Perfect. All right, so here we have our medial malleolus, our calf muscle. Okay, our calf muscle. We call that the gastrocnemius. It has a tendon attached to it because what are tendons? They attach muscle to bone. This one's going to go all the way down to the calcaneus. This is the Achilles tendon. Okay, that's going to be the Achilles tendon. Let's look at your actual ankle bones. Okay, your ankle bones. There are several, but again, we can call them all just one grouping. We can call them the tarsals. Okay, tarsals. But there are the one I at least want you to know is going to be the heel bone, and we call that the calcaneus. Calcaneus. That's this big old heel bone. But see, you have like the navicular bone, you have the talus, you have the cuneiforms. There's three of them. On the opposite side, you have a cuboid. But just call all of them the talus. But if you see something that says, oh, what's the heel bone called? Calcaneus. So those are, come on, buddy. Come on, where'd you go? There. Wait. Yeah, so from the talus all the way to here, those are your tarsals. Okay? Going down, or again more distal, you have the foot bones, if you will. So just, I think it's on the next page. All right, back at it. So now the physiology of the skeletal system. So what is the purpose? Yeah, we just named a bunch of parts and different bones, but what purpose does it serve for you? Well, the skeletal system gives the body its shape. So its recognizable shape that we all know. Boom, that's one purpose, right? Protects fragile organs, right? It's just basically a rock. That's what your bone is, basically a rock. It protects a lot of good organs, okay? Allows for movement, right? How it works is you have muscles that are connected to the bones by tendons. Those muscles contract, get smaller, and that causes the bone to move, right? Your muscles are constantly working to stabilize all your joints, just so you can stand upright, but also to manipulate your environment, to walk, to pick up a pencil. Stores calcium. Again, your bones are just big old calcium rocks. When you need calcium, like just to have everyday functioning of your body, and you don't have it with your diet, your bones might start to get rid of its calcium, which is not great, right? You want to have a healthy balance of all your nutrients and vitamins. Helps create blood cells. That's going to be inside of the bones, especially your long bones. You have a bone marrow. You have a medullary cavity, and you have some blood production and storage going on. This one's on me. This one's on me. I got to click on, because I clicked onto the presentation view and not onto the PowerPoint itself. Every time. If you hear that, we had a rainstorm and our classroom flooded. All right, well, let's go ahead and save this guy. Walk of shame over here. So, the tarsal bones, we've got that. Metatarsals, just like with the... Oh, I think it's because I'm recording. It's because I'm recording, that's why. So you can't, you just went over. You just went over. That's the problem. So pause. Where did we leave off? Well, again, I don't think we finished with all of this, but let's kind of start over because we had that whole crash out. I was perfectly fine. To understand what is abnormal breathing, you first need to know what is normal breathing. So the characteristics of normal breathing. Again, normal rate and depth. We talked about it. A normal resting breathing rate for an adult, 12 to 20. Adequate tidal volume is something you're more going to get an appreciation for once you start working on a consistent basis. You're going to see, oh, this person is adequately getting air in and out of their lungs. Okay, but if you can barely see it, as in you can barely see that chest rise, or that chest is rising way too much than what is expected, that is abnormal. All right, but normal, just normal rise and fall of the chest. Clear or the regular rhythm and pattern. So you're looking at both the interval between each breath, or respiratory cycle being inhalation, exhalation. So is it consistent, right? Is that time between each breath consistent? Also, you're looking at, hey, does it speed up, slow down, speed up, slow down? Does it stop at any point? But you're also looking at that chest rise again. Is it the same amount of chest rise with every single breath? Okay, if there's something that changes and it's getting deeper, then it's getting shallower, and there's a rhythm to that, that's something you're looking for. Clear, audible breath sounds on both sides of the chest. Remember, during your primary assessment, you're doing a rapid chest auscultation. Where are we going to assess that?
Lungs.
We are checking the lungs, but anatomically speaking, where are we going to put that stethoscope, that bell of the stethoscope, for rapid auscultation?
On the anterior portion of the thorax cavity.
No, more specific. Okay, we're on the right path, mid-axillary line, but where? Good. So mid-axillary line between the 5th and 6th intercostal space. So where's the mid-axillary line located?
Right here.
Armpit. Axilla is referencing the armpit. Mid is middle. You're going to go down to the 5th to 6th intercostal space. Breathe there. Opposite side, breathe there. We do everything bilateral, okay? Bilateral. So that is the rapid auscultation. Now, when we do the full set of anterior-posterior auscultations, I want your partner to do that. 6 points on the front of the chest, 6 points on the back. What are you expecting to hear? Not much, right? It is literally just like wind blowing, right? That's all you're just hearing a normal inhale, exhale. There shouldn't be any real weird sounds at all, okay? And that is what we call just normal breathing. Abnormal, which we'll talk about in a second. We'll talk about it. Yeah, I don't want to get into it. Regular rise and fall movement of both sides of the chest. So again, it should be equal, right? The right side and left side chest rise and fall should be equal. And consistent. Movement of the abdomen. Okay, now why is your abdomen slightly moving? It's because your diaphragm is dropping into the abdominal cavity essentially, so you might have some movement. This is just not the day. I blame the water. It's just. How was the rain where you guys were? It was like pouring last night, like crazy. Right. I don't know how my trees like stayed. I was like, oh my gosh, absolutely wild. Cool. Okay. All right, inadequate breathing. So now that we have a baseline of what normal breathing looks like, now what is inadequate? Labored breathing. Okay, so this is just like an increased work of breathing. So it just kind of looks like they're a little short of breath and it's taking more effort to breathe. Okay. Muscle retractions. Okay. Very common in our pediatric patients, but you might look at their neck, their chest, and you'll see like the skin is being sunken in around the bones. Okay. Those are called retractions. Or you see the skin kind of wrapping around the muscles. Not to be confused with just flexing, right? Because when you have an accessory muscle use, you're going to see the muscles kind of flex, and that's how you know they're operating, right? You see a muscle move in some fashion. Pale, cyanotic, cool, or damp skin, okay? So breathing correlates with perfusion, okay? They're going to work hand in hand with each other. So a patient who is not getting adequately oxygenated, okay, their skin signs are going to start to change, right? So they might become more pale, might turn bluish or gray. Their skin might become more damp and wet, if you will. Hey, buddy. Oh, yeah. I know, right? Yes, I don't know if there's like a leak down here or from the emergency exit it just started coming this way or what, but it's all centered right here.
Okay.
Yeah, you do you. Tripod position. As we talked about, you come on scene and get that general impression going. You're going to see a person in a certain position. Tripod position, they're going to be in that Fowler's position, arms on their thighs. They're sticking their chest up, right? They're trying to reduce the amount of muscle, essentially workload on the chest and lungs so they can just breathe easier or at least make less effort. An agonal gasp, okay? An agonal gasp is essentially a random, and there's nothing, okay? Essentially someone who is died, so to speak, might do an agonal gasp, but it's going to be like a random, like one random breath, and that's it, okay? That is not considered normal breathing, as you know, so don't treat it as normal breathing. Keep doing your CPR or assist with ventilations. Finally, the circulatory system. So the circulatory system, we're talking about the cardiovascular system, okay? What are the components of the cardiovascular system? What do you got? What do you guys think?
Heart, lungs.
So we got heart is one, lungs, pulmonary system. Veins and arteries. One more big component. Not the brain. Already got the heart. Lungs, pulmonary system. Blood. I love it. Those are the three big components, all right? You have the pump, which is the heart. You have essentially the tube or the transportation tunnels, which is your artery and veins. And then you have the actual fluid component or the transporter of blood. Okay? Those all have to be in working order or else there's circulatory compromise. So we have arteries. Arterioles are smaller arteries. We have capillaries, which is kind of a webbing of more or less tissues. That's where diffusion will take place. Venules are just smaller veins. There are two circuits, a systemic circulation and pulmonary circulation. So bringing this blood to the body, bringing the blood to the lungs. And here it is. So here is essentially all the components of that circulatory system. And it's kind of explaining the pathway, if you will. The blue represents deoxygenated blood in this graph. The red is representing oxygenated blood. Okay? Is your blood blue? No, it's not. It's just red. It's just red. I know.
CO2.
TV lied to you back in the day. It's all red, but now there are different shades of red. Okay, so there is that. Deoxygenated blood is a darker, deeper red. Oxygenated blood is a more vibrant red. Okay, but they're still both red. Now let's do this. Okay, are we going to do this? We're going to learn how blood goes through the heart. Yes, we are. Yes, we are. Oh, and we have a marker. Okay, I do like to draw this one. Kind of gives me a break. Let's start, obviously, with the heart. Let me see if I can zoom in on the board. I want the world to really see my artistic prowess. There it is. Oh, wait, that's way too much. That works. Okay. Usually I'd have different color markers so I can represent the different types of blood. But let's start with the heart. Okay. What is the heart? It's just an organ, right? It's a hollow organ. Now, keyword is hollow. Okay. There are 4 chambers inside of that heart. Okay. So let's draw our heart. Let's just do our heart. And this is not to scale, okay, or anatomically correct. Lovely, lovely. Here's your heart. We're going to divide it into 4 chambers, okay? Perfect. Now again, we are looking from the patient's perspective. So there is a right side of the heart, there is a left side of the heart. Okay? So let's start naming the different chambers. Okay? You have 2 chambers on top, 2 on the bottom. Who can tell me what the chambers on top are? They're atria. Okay? So you have a right and a left atrium. Okay? So again, we're doing patient's perspective. So which side is this? The right. So this is going to be the right atrium. Okay? This one would be left atria. Perfect. Now, inferior to that, you have 2 other chambers. These are called ventricles. Ventricles. We have a right ventricle. We have a left ventricle. Perfect. Perfect. That's step 1. We now have a heart. So let's go ahead and start with the blood returning to the heart. Okay. So typically how we started off with is we have 2 of the largest veins in the body dumping deoxygenated blood into that right atria. Those 2 vessels are called the superior and inferior vena cava. Okay? Superior and inferior vena cava. And I'm going to have a little list going right here. So that's what we're going to start with. Superior, inferior vena cava. Excellent. So we're dumping all that deoxygenated blood that is very high concentration of waste product, carbon dioxide. It goes into the right atrium. Perfect. Now, the atria and ventricles contract at different points, okay? So the two atria will contract together, then the two ventricles will contract together. That's kind of where you get the wub-dub, 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 wub-dub. The atria are contracting, then immediately after the ventricles contract. So right now we're sticking on the right side of the body. So when that right atria contracts, it's going to push blood down to the right ventricle. But it's going to go through a little valve right here. We're going to call this the tricuspid valve. The tricuspid valve. Perfect. Now, this valve, that's a specific name for it. Now, it has a grouping name as well that you might see more commonly. It all just depends. This is what we call an atrioventricular valve. An atrioventricular valve. Atrioventricular valve, tricuspid valve, okay? Now, this is essentially what we call a clapper valve in the industry, if you will. This thing is closed, but when pressure is applied, it essentially opens up the door to allow blood to flow back through that to that ventricle. But once pressure is equalized, that pressure is going to slam the door shut. That way you don't have the blood that just got into the right ventricle backflow to the right atria, because we always want that blood to keep moving forward. Okay, so that's the whole purpose of that valve. So now we're into the right ventricle. Perfect. Then again, ventricle. The right ventricle is going to do what? It's going to contract. So it gets smaller, pushing blood forward. Where's it going to go? Well, just like going from the right atrium to the right ventricle, it needs another valve. Okay, so we have another valve. Okay, now depending on the textbook, you might hear it different ways, but this is going to be the pulmonic valve or pulmonary valve. So if you call it pulmonary valve, that is fine as well. This valve also has a special grouping. This is a semilunar valve. A semilunar valve. Semilunar valve. So now, yes, in the back.
Why is it called the semilunar?
I'm assuming it has to do with its shape. That's all I got for you. I don't have all the answers. I don't have all the answers. I just know that's what it's called. You didn't ask me why it's this one, huh? Yeah. Well, that's because it's the atrium. I love it. So we are now leaving the heart. That's the important key thing. We are actually getting that blood out of the heart, and it's going to go to the lungs. Okay, but it has to. How's it going to get there? There's a vessel. Okay, it's going to go through the pulmonary artery. I'm going to go this way. I don't want to go that way. I don't want to go that way. I'm going to go this way. Again, not to scale. Not to scale. Okay, and then we're going to have this guy. Okay, let's get rid of that guy. We're going to have this guy. Perfect. Perfect. Yeah. Pulmonary artery. Okay? Now, what is unique about the pulmonary artery? Who can tell me? Who can tell me? In the back.
The only artery that has deoxygenated blood.
Fantastic. This is the only artery in the body that carries deoxygenated blood. Okay? So that makes it kind of special in its own little way. But it still holds true to arteries' overall principle, which is arteries take blood away from the heart. Okay? All arteries take blood away from the heart because we left the heart and we're going to the lungs. Okay? So that concept still holds true, but it is the only artery with deoxygenated blood. So now we're in the lungs. More specifically, where are we? The alveoli. More specifically than that, where are we? What is surrounding the alveoli? Pulmonary capillaries. Pulmonary capillaries. So this is a spot where diffusion takes place. Again, this is going to be our external respiration. We have high concentration of oxygen chilling out in our lungs. We have high concentration of carbon dioxide inside our blood. And then we have the inverse of each other. So we're going to grab onto those oxygen molecules from our alveoli and our pulmonary caps, bring it into our blood. At the same time, we're getting rid of the carbon dioxide and pushing it into our lungs. So when we exhale, we're getting rid of that carbon dioxide waste product that our body created. But in the same breath, we are oxygenating our blood. So now our blood is oxygenated. Now our blood is oxygenated. So what do we want? We want to bring that blood to all the tissues on our body to keep them perfused and oxygenated. So now we need to go back to the heart. And that's what we're going to do. Again, not to scale. So we're going all the way back to the heart, to the left atria. But what is that vessel, right? What vessel are we going to take? We're going to take the pulmonary vein. Pulmonary vein. Pulmonary vein. What is special about the pulmonary vein? It is the only vein that carries oxygenated blood. But it still holds true to what veins do. It brings blood back to the heart. Okay? Because we already saw it once before. The inferior vena cava and superior vena cava are just veins. They're the largest veins of the body. It brings deoxygenated blood, or brings blood rather, to the heart. Okay? So now we brought oxygenated blood back to the heart, and we are at the left atria. Left atrium. Once again, our atria contract together with the purpose of going to our left ventricle, but we got to go through another valve. Which one's this called? The bicuspid valve. Okay, bicuspid valve. You might also see it written as mitral valve, but bicuspid is the more utilized one, at least where we're at. So. Now, what kind of valve is it? Atrioventricular valve. La, da, 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 da. There you go. So we made our way to, I'm sorry, over here, the left ventricle. So now we're at the left ventricle. Perfect. Left ventricle is the most meaty muscular part of the heart. Okay? It is the big pump of the heart because it has to pump through a bunch of pressure to get blood to the body. So it's going to be the strongest, if you will. So it contracts. Once again, it needs to go through another valve. This is the aortic valve. And what kind of valve is it? Semilunar valve. Semilunar valve. Okay. So now our whole goal now is to bring this oxygenated blood to the tissues. So let's make it happen. First step, we have one of the great vessels, the aorta. So it's a big thing on the top of the heart. It's going to branch into an ascending, so going up, descending aorta. And then it's going to make its way to, make sure, stay on track, aorta, arteries. So we're at the arteries now. And we know some things about arteries, right? Carries, well, for the most part, carries oxygenated blood under a lot of pressure. We know that there are pulse points all over the body, so there's arteries all over the body, and we'll cover like all the different types of arteries, okay? Then where are we? We're going to go to smaller arteries that we call arterioles. Okay. And now we've made our way to capillaries. There are billions of capillaries, and that's billion with a B, all over the body. It creates a web-like kind of structure to all of our tissues, because all your tissues need oxygen to survive. Okay? At this point, we have internal respiration take place. So we have diffusion happen again. We are dropping off oxygen to those tissues. And in the same breath, we are taking in carbon dioxide, that waste product that was created by the different tissues and cells. So now our blood has become deoxygenated. So now what?
We start back at 1.
We need to start bringing that deoxygenated blood, those waste products, back to the lungs to get rid of them, and then to reoxygenate the blood. So we're going to start our journey back. we're going to start our journey back by going through something called venules. Venules. Venules are smaller veins. So we're going from very big structures to very microscopic structures back to very big structures. So we can't just go back to big. We have to go small, big, biggest. You know what I mean? Yeah, it's got me. Venules. Okay? Then we are going to veins. And then what did we learn about the superior and inferior vena cava? They are the biggest veins in the body. So it goes right back to the superior and inferior vena cava, back into the right atria. Any questions? So that is the pathway of blood through the heart. Now, obviously, what I just wrote is the exact same thing that is shown up here, just in a more simplistic way. And this is definitely more, anatomical in a sense. Excellent, excellent. Good? Everyone's good? Moving on? All right. So, do you need to memorize this? Mm-hmm. Yes, you do. Yes, you do. In all its glory. Again, some people can draw pictures. That's fine. It's all good. Some just like a standard list. You do need to know all these components. Now, obviously, you're asking yourself, why? Right? Why do I need to know this? It's to be a better medical provider and to understand how the body works. Okay? We're going to understand a person has a heart attack. So they have death of muscle somewhere in this heart. Okay? What happens when you have an injured muscle? It doesn't work efficiently. So it doesn't work like it should, right? I'm sure most of you have hurt your body in some way. It doesn't operate like it should. Same thing is happening here. Let's say you have little death of tissue in your left atria, right? Everything else is working fine. But now your left atria isn't pumping as hard, isn't pumping as fast. The right ventricle is still pumping its same amount of volume, but now the left atria is not pumping the same amount of volume. So you're going to have a backing up of fluid, in this case blood, back in the circuit to the lungs. So that's why you would get a bunch of fluid buildup, blood, inside of the lungs when someone has what we call left-sided heart failure or a left-sided MI. Okay? Same thing can be found here. If there's damage or death of tissue in the right side, blood is going to start backing up to the inferior superior vena cava. So you might see a patient with swollen feet and ankles because blood is going to the most gravity dependent area through the inferior vena cava. So blood is kind of filling up into those ankles. You might see your jugular veins kind of bulging out because it's just jam-packed with more blood than it should be there. Okay? Those are signs that if a person's having chest pain, you're looking for, because that's going to help strengthen the evidence that this person's having a serious heart condition of some sort. Okay? A lot more than just that, but broad strokes. All right, so make sure to memorize that. Perfect. Okay. So again, this is going to be a little bit of a review since we just kind of covered a lot of this in my little ramblings. That's good. Once again, the heart is a hollow muscular organ made for specialized cardiac cells. Works as two paired pumps. Again, the atria and the ventricles pumping. Atrium, upper chambers, ventricles, lower chambers. The technical term for heart muscle is myocardium. Okay, myocardium. You do have what's called a septum. Septum is just a term referencing more or less a divide. It's kind of like a barrier, if you will. So this would be the septum. Good. But again, the whole point about circulation, the heart receives its blood from the aorta. Yeah. heart receives its blood from, oh, okay, I was like, what are you talking about? In terms of oxygenated blood, so again, the heart itself is just muscle too, right? So it also needs oxygen. But when it's in the chambers, the heart is not utilizing any of that, okay? It's still just like all the other organs and tissues, has to go through the process. So it's going to go through the process and get its own through the coronary arteries, okay? And again, we're going to talk about the different arteries in a second on like where it's supplying, what tissues are getting supplied by what artery. Right side receives oxygen in veins, left side, okay, we're going to cover that. Again, just more diagrams. We already covered that. Okay. For an adult patient, normal resting heart rate. So again, that means everybody in here at rest. There's no stressors being applied necessarily. Your heart should be between somewhere to 60 to 100. Okay, that's where you should be kind of hanging out. But that is kind of the norm. That's your baseline. Some individuals have different baselines, okay? Might be a little bit higher, might be a little bit lower, okay? More times it's on the lower side of things, and that's going to be typically for the individuals who are really well-trained athletes. Essentially, it just means that at rest, their heart doesn't have to work as hard to supply all their body with oxygen because their body just actually works more efficiently, okay? Because they've trained it in such a way. Very common in our endurance runners. A couple little key terms to know. Stroke volume. That is the amount of blood being essentially pumped in one contraction. More specifically, we always talk about the left ventricle. Now, can you measure that in the field? No, you cannot. So it's more just be aware. Cardiac output. Okay, cardiac output is stroke volume times the heart rate equals cardiac output. So that's how much blood is pumping in a minute, or that's more how efficient or effective, or just in general how much is being pumped in 1 minute. Can you assess that in the field? Also no. Also no. So don't get hung up on that. It's more just about definitions to understand and be aware of. The conduction system. Okay, so as I talked about, heart is specialized cells. It has something called automaticity. It has its own conduction system to allow contraction to occur at the atria and the ventricles. Okay, we're going to go a little bit more in depth when we get to cardiovascular emergencies, but let's kind of go through it. Specialized tissue capable of initiating and conducting electrical current, perfect, causes smooth, coordinated contractions. Contractions produce the pumping action. Okay. It's not going to go into it. That's fine. It's not. It was very superficial. Don't worry. When we get to chapter, I want to say 16 or 17, we'll go more in depth of talking about the different nodes and how it actually goes through the heart, and then what happens when there's a malfunction or there's an issue. Arteries, we kind of hit on. Again, arteries carry blood from the heart to all body tissues. Aorta branches into coronary arteries, carotid, hepatic, renal, and mesenteric. Okay, the coronary artery, and there's more, but the coronary arteries supply oxygen to the heart muscle. Carotid arteries supply oxygenated blood where? Where is our carotid artery located? The neck, right?
Probably goes to your brain.
Good. Your brain, face, your head, your whole head. Hepatic. It's going to be your liver. Good. Renal. Kidneys. Great. Mesenteric.
Is that for your gastric system, like your stomach and everything?
You're right there. The intestines. The intestines. Excellent. Fantastic work. Pulmonary artery, again, carries oxygenated poor blood to the lungs. Arteries branch into smaller arteries and then into arterioles. Arterioles branch into a series of increasing smaller vessels until they connect to the capillaries. Perfect. Already covered all that. Excellent. Your pulse. Okay, we covered this a lot in lab. When that left ventricle contracts, it creates a wave that is going through your arteries. So it has an increased pressure wave. That is relevant because to assess someone's heart rate, you can find a pulse point and then calculate it. How do we calculate it?
By counting them over the span of 15 seconds and multiplying by 4.
So here we're just going to do 30 seconds. You could do 15 seconds, but best practices.
I haven't been taught.
Sorry.
That was high school.
No, that's okay. It's okay. I used to go with that way as well, but you guys are just starting out, so we kind of want you to be more precise, less errors. It's a lot easier for you guys to multiply something by 2, no offense, versus multiplying it by 4, okay? So yeah, you're going to find a pulse point. Typically, it's going to be the radial, carotid, femoral, and then you, in a 30-second window, you're looking at your watch, count how many times you feel that pulsation, multiply it by 2. That gets you your heart rate, okay? So it's how many times the heart is beating per minute. And it should, for a person at rest, be between 60 and 100. Excellent. So here's a bunch of different artery points, or arterial points, pulse points, if you will. Yeah, I guess pulse points wouldn't be really accurate because, yeah, these are a bunch of different arteries, but you can't necessarily feel a pulse at each one, all right? But there's a lot. You do not need to memorize all these. Okay. Only the ones that we learned in lab is totally fine. Again, carotid, brachial, radial, ulnar, femoral, popliteal, dorsalis pedis, tibialis posterior. Those are like, boom, that's fine. And apical. I like to throw apical in there. Excellent. Capillaries. Once again, they connect arterioles to venules, fine end divisions of the arterial systems, allow contact between blood and the cells. Excellent. I'm pretty sure we're going to hit on this, but what is blood? What is blood, right? The biggest thing is a transporter of stuff, right? But what is it actually transporting? Good. So that's one of the key components, right? Oxygen. Now, where is the oxygen located? Supposed to be located, because it doesn't always have oxygen in there, right? So what are the 4 components of blood?
Cells, red blood cells.
Red blood cells. Okay, those we call those erythrocytes. White blood cells, we call those leukocytes. Good. Platelets, awesome. What are platelets used for? Clotting, excellent. And lastly, plasma. That's the fluid component, okay? So those are, now obviously there's like some more stuff in there, but those are the main components of blood, okay? Red blood cells are typically, you have your hemoglobin, and that's going to transport the waste product and oxygen. You have your leukocytes, which are your white blood cells. Those help fight infection. Platelets, those help with what we call coagulation. So someone's injured, they're bleeding out, platelets will go to that area and start clogging the gap or hole, so to speak. And then again, plasma is just the fluid component. Already hit the veins, we're fine there. Perfect. The spleen, let's go through some organs rather, okay? You are going to be tasked with knowing where. Still not there. You are going to be tasked with knowing where the organs are located underneath the skin, okay? Most of the organs, not that hard, right? But when you get to the abdominal cavity, that's where it gets a little tricky. It's all about having reference points, understanding, hey, the umbilicus, which is your little belly button, that is going to be like the midpoint reference. And then you're going to draw imaginary lines to divide that abdominal cavity into different quadrants, okay? Different quadrants. The spleen. The spleen is a solid organ. It is very important to understand the difference between a solid and a hollow organ. That also kind of helps with understanding the function to an extent, a little bit. But the issue with solid organs is that they're very susceptible to blunt trauma. So that's essentially stress that is applied to the body without breaking the skin. Okay, so like getting punched, getting hit with a baseball bat versus getting stabbed which would be a penetrating trauma, right? Because it's a solid organ, it's very susceptible to those blunt traumas. Now, obviously, also susceptible to penetrating trauma. But the issue with most solid organs is that they're very heavy bleeders, okay? So they're going to bleed a whole lot, especially the spleen. Because one of the key functions of a spleen is to filter out the impurities of blood, okay? Which means there's a constant flow of blood going through that spleen, okay? Constant flow of blood. Now, what quadrant, if you will, do you think that spleen is located? Here's a hint. It says under the rib cage, so probably in an upper quadrant. So now, right or left?
Right. Your heart's just getting off, no? So
the heart's way up here. So we're down in the little belly area, right? So typically we have in the right upper, we have the liver and gallbladder. Left upper, we have stomach and spleen. You got the pancreas kind of lies in both uppers, right, and kind of in the center. In the right lower, you're going to have your appendix. You're going to have intestines in all four. When we start going into like reproductive organs too, there's going to be in the lower regions. Depending on how you look at it and how your textbook looks at it, the kidneys, they kind of consider in the upper right and upper left. I don't really agree because there's another term we can use on location in the retroperitoneal area, which I like more. And there's in the flanks, your kidneys in both the flanks. But when we get to that chapter, we're going to go a deeper dive into it. Again, blood composition we already covered. Beautiful. Already hit on those. We're fine. Blood pressure. Yeah. We covered blood pressure this week in lab, except for my Thursday group. Hopefully you'll do that tomorrow. What is blood pressure? Is it up there? It's up there. It's fine. It's fine. It's pressure that blood exerts against the walls of the arteries. Okay. So there's always blood in the arteries, right? If you're alive. So that means there's always some form of pressure. Okay. It's just fluid in there. So there's got to be some form of pressure on those artery walls. Okay. But now, what also goes through those arteries? That pulsating wave. When that left ventricle contracts, that pressure wave goes through the arteries. So that's obviously going to drastically increase the pressure on the walls of the arteries. Okay. So when you're assessing for pressures, that is one thing you're looking for. You want to know what is the most pressure being exerted on those walls, and then what pressure is being exerted at rest. And when we say at rest, we're just talking about the time between the pulses, between those pulsating waves. What's that pressure? And then what pressure is the wave causing? Okay. And we have two distinct names to call those, systole and diastole. Okay. So you have a systolic blood pressure and a diastolic blood pressure. That systolic blood pressure is that maximum pressure wave going through those arteries. And that's when that left ventricle is contracting. The diastolic is that pressure in between the pulses, okay? In between the pulses. So we want to find both, because that's going to kind of go into pulse pressures and whatnot. You can kind of tell a lot about the patient. And their blood pressure overall can tell you how they're being perfused, at least how blood is circulating, right? Because if they have very low blood pressure, then they might not be getting the enough blood to those particular areas to be oxygenated. Okay? But there's also a very real possibility that a person could have really good blood pressure that should sustain life pretty well, but still be hypoxic, still be hypoperfused. And that's because maybe there's not oxygen inside the actual blood. Okay? So there are different components that all need to be met for actual perfusion and oxygenation to take place. And then how it's written typically is like a fraction. So you have a systolic number over a diastolic number, okay? And it's more just for the aesthetic, okay? Just the aesthetic. You're not actually like dividing, or it's not like an actual fraction. normal circulation in adults, right? So just like with breathing, you need to know what normal is to understand what abnormal is. Normal, automatically adjusted and controlled. So again, it's not something you have to consciously think about. If there's a problem with perfusion, if there's a problem with your circulatory system, your body will try to self-regulate to kind of make up for the demands. Now, sometimes it has to kind of do a lot more to do that because it depends on what's going on, right? If you having a heart attack, that means you're not getting adequate effective pumps, which means it's going to lead to a state of hypoperfusion. So your body doesn't like that, right? So what's it going to do? It's going to release a bunch of hormones to cause your heart to beat faster, okay? To kind of make up for that lost pump of strength, if you will. Okay. If you have a lack of blood fluid or volume because you're bleeding out, your heart's going to beat harder, your heart's going to beat faster, your blood vessels are going to constrict and get smaller. That way, it takes less volume to get farther into the circulatory system. Okay, and we'll get deeper into that as well. Some definitions: perfusion, circulation of blood in organs or tissues in adequate amounts to meet the needs of the cell. Perfect. Everyone? Yes, question. Lay it on me.
Pop into my head. So when women are on their cycle,
Yep.
are their heart rates that week, are they extremely high or?
It wouldn't be extremely high. I mean, it's a case-by-case basis. But as it's happening, yes, because they are in a state now. The body has adapted to that cycle, so they have more blood than a male person would have. So it kind of makes up for that. But again, there's always a potential they lose too much blood. Okay, so that's a real possibility, and that might become a 911 call because the patient starts exhibiting signs of hypovolemia, hypovolemic shock. Lots of variables there too, but it's a great question. A state of hypoperfusion that we talked about. Another term commonly used is shock. Okay, is shock, but the proper definition term is hypoperfusion. Okay, hypoperfusion, inadequate blood supply to the organs, tissues, and cells. And there's a whole chapter just on shock or hypoperfusion because there's different categories of shock and there's different compensatory mechanisms for shock. Okay, and we'll cover that later on in different chapters. Now, what is inadequate circulation? Well, again, the system has the ability to compensate, okay, to adjust for small loss of blood. Like we just talked about, vessel constriction, heart beats faster, heart beats stronger. With a large loss, adjustment fails and the patient goes into shock. Mean arterial pressure can help detect shock. So that, again, is more you're looking at the systolic, diastolic numbers and seeing if there's a downward trend or more so an upward trend, depends how you look at it, but widening pulse pressures. It's just basically saying that blood pressure is starting to drop, so to speak. And we'll cover that again, more in that shock chapter. Functions of the blood we kind of already hit on. Fighting infection, transporting oxygen, transporting carbon dioxide, controlling pH. So that is your acid and base inside of your blood. That has more to do with your metabolic side of things. Again, we'll cover that way more in depth later on. Transporting waste and nutrients, and then clotting, which is that coagulation component. Okay, continuing on. We are now to the nervous system control of the cardiovascular system. Okay. The biggest influence, if you will, that the nervous system has on the cardiovascular system has to be with the sympathetic portion of that nervous system. Okay, the sympathetic nervous system. This is what we commonly will refer to as the fight or flight response. The fight or flight response. So when you yourself come to a specific stressor or any real stressor, your body is going to react. Okay, let's say a car just stopped right in front of you or cut you off, and you kind of jolt a little bit, right? Your sympathetic nervous system essentially jumps into play. Okay, or let's say there's a wild coyote coming at you. All right, your fight or flight response kicks in. Now, what does that mean? It means your brain sends signals, okay, to essentially your endocrine system to release different hormones, okay? Adrenaline, norepinephrine. Adrenaline is just epinephrine, cortisol. Essentially things that are going to influence the heart. Specifically, it's going to cause your heart to increase in speed, increase in contractility, okay? Because it essentially wants to provide more oxygen to your skeletal muscle. Because essentially, it is preparing your body to either fight the stressor or to run away from the stressor, okay? It wants you to have maximum amount of volume of blood supplied to those muscles so you can either fight or get away. Okay, it's like a survival instinct, if you will. So it's not, yes, Mark.
Is that feeling like when you wake up out of your sleep, like you jolt, and do you know what I mean? Like I don't know, you just wake up like you felt like you were falling, and
Yeah, that's more. Yeah, it plays a role for sure because your brain thinks that it's actually in a dire situation, such as falling from a plane, being murdered, and then like, oh my gosh, let's wake up, and then you kind of like breathing very heavy, your heart's racing. Yeah, same kind of concept applies.
I get so mad.
Same kind of concept applies. I love it. So it is not only impacting your heart, though. Okay, it's all components of the cardiovascular system. Your blood vessels. Okay, it's going to constrict blood vessels to non-important systems, so to speak, like your digestive system. We don't really care about digesting food at this point. We're trying to survive. So it's going to constrict blood away from those points or areas and go to more vital areas, in this case, skeletal muscle. Okay. Your respiratory rate's also going to have an impact here. You're going to increase your work of breathing, increase your breathing rate and depth, again, to get more oxygen on board. That's the key. No, I was so close. Perfect. All right, continue. Blood vessels have alpha-adrenergic receptors. The heart and lungs have beta-adrenergic. So again, basically, it's just how these hormones are going to attach to these different receptors to cause different outcomes. Again, increasing that heart rate, increasing the contractility, increasing respiratory rate, bronchodilation. So again, it's going to cause your bronchioles to dilate, so become bigger, so you get more airflow in. The heart and lungs, baroreceptors sends pressure in the blood vessels. Sympathetic and parasympathetic nervous system balance each other out. Yeah, so you have a sympathetic nervous system and a parasympathetic nervous system. Typically, they're both working together in a sense to create equilibrium, okay, to create balance, right? We don't want to be too high, we don't want to be too low at any given point. But it depends on the circumstance. When we're fighting a stressor, maybe when you're going to be performing or doing like your scenarios in front of everybody, your sympathetic nervous system is going to kick into drive a little bit because of the anxiety, okay? But let's say when you're going to go to sleep, you don't want your blood pumping and adrenaline going while you're trying to go to bed. So your parasympathetic nervous system kind of takes over so it can actually calm everything down and you can go to sleep, okay? It's like resting your whole body. But in the everyday right now, there's a balance, right? We're trying to just stay alive and awake and functional. Once again, let's segue, like I just said, into the nervous system. The nervous system, again, is the most complex body system of the body. It controls just about everything. It's very intricate. It's very unique, so to speak. You can break it into two divisions, the central nervous system, which we're going to kind of more focus on just the brain and the spinal cord. And then we have the peripheral nervous system, which is just everything about the nervous system that's outside of that brain and spinal cord, okay? I guarantee this is probably not going to work. Oh, it worked. Awesome. Let's talk about the brain. Again, this is anatomy and phys. The brain has three major subdivisions. Okay, you have the cerebrum, the cerebellum, and the brain stem. cerebrum, cerebellum, and the brainstem. So those are the main subdivisions, okay? We're going to kind of go a little in depth eventually on what functions each portion of the brain has. So just be aware of that. Cerebral spinal fluid, okay? That's kind of like the medium in which those electrical impulses are going to travel in. It surrounds the brain and the spinal cord. It also acts as kind of like a cushion as well. So it has like, multi kind of purposes and functions. Circulation in the head, oxygenated blood is supplied via the carotid arteries. Deoxygenated blood is drained by the internal external jugular veins. Perfect. So inside of that vertebral column that we talked about earlier, you have this, okay? This is the actual spinal cord, if you will. It's the extension of the brain, transmits message between the brain and the body, okay? So you have constant messages going to and from that brain. Okay, you have sensory nerves, motor nerves. Sensory nerves is just information that's being collected all over the body, and it sends those signals to the brain to essentially what is going on. It's just talking to each other. Then the brain sends these motor essentially messages down to the body to actually move. Okay, so you're touching something that's uncomfortable or hot. Your brain's going to send a signal to move it. Unless we're into this like reflex cycle thing, we're not going to get there. The PNS, the peripheral nervous system, again, that could be further divided into two subsections, the somatic and the autonomic nervous system. The somatic nervous system transmits signals from the brain to your voluntary muscles. So again, more talking about the skeletal muscles, where the automatic is all about your involuntary actions, your smooth muscles, more or less. And that's also further split into two divisions. And that's what we already just talked about, the sympathetic and the parasympathetic nervous system. So again, there's like a whole kind of tree that's going to like branch from each one of these things. Two types of nerves within the peripheral. You have the sensory and motor. Kind of already hit on that. Perfect. So again, not a whole lot. We're going to kind of speed through a little bit because we're running out of time. But like I told you, at the start of every other chapter, when we get to the medical emergencies, we'll hit on anatomy and phys. Your integumentary system, that is your skin, okay? You have two layers. You have the epidermis and the dermis. The epidermis is more the superficial layer, and we'll see a little picture diagram of that soon. And then the dermis is underneath that. Underneath that, you have the subcutaneous tissue, okay? And that is going to be your adipose tissue. That's your fat tissue, okay? The whole purpose of the adipose tissue is to insulate, and then it is also an energy reservoir. So that means if your body doesn't have the carbohydrates, or more or less the carbohydrates and the proteins, it'll start eating away at all the fats that's stocked up in your body. Here's a nice little diagram. So again, you have that top layer is the epidermis. Again, what is the purpose of the skin, right? For the most part, one is protection, right? It protects you against the environment. It's a nice solid layer of protection. The other part of the integumentary system, at least major part, it regulates body temperature. Okay, that's a very key component of the skin. Now, how do you guys think it regulates body temperature? Sweat. Sweat is the key. Now, is it just the water from the sweat? Like obviously it's not just water. Is that cooling you down? Just like the perspiration? Okay, there's a release of heat. It's the evaporation of the sweat. The evaporation of the sweat. That actually cools your body down. Okay? That's why it's a lot harder to cool your body in a very humid area, because it just doesn't evaporate. There's too much water in the actual atmosphere. So then as we go down, we got the dermis. This is where a lot of your things are stored, like your hair follicles, your nerves, sweat glands, all that fun stuff. Going down, you have that layer of subcutaneous fat or adipose tissue. And then underneath that, you got your muscle. You got your muscle. The skin is the largest single organ in the body. 3 major functions: protects the body, regulates body temperature, and then transmits information from the environment to the brain. And that's all through the sensory nerves. Okay, the sensory nerves. The digestive system. Okay, this has a lot to do with just eating and drinking, and then more breaking down those items and extracting the nutrients. It can be your gastrointestinal system. You have the abdomen, second largest body cavity, only secondary to the thoracic cavity. Contains major organs of digestion and excretion, organized into 4 quadrants. So we have a right upper, right lower, left lower, with the umbilicus being the divide, the center point. Okay, when you get into a further along in your medical careers, it might branch into 9 different categories or sections, quadrants, if you will. But for now, we're staying with the basic 4. Makes life is easy that way. So here we go. So there's the divide. Again, there's more to it, but this is like the big one. So again, on the right upper, liver, gallbladder is the big one. Left upper, stomach and spleen. There's no pancreas in there, but I swear it's there. Going down, your appendix is lower right. Intestines are all, so you have large intestines and small intestines present in all quadrants, okay? The rectum, sure, it's kind of like right in the middle, right? Yeah, that's about it. There's more. Diaphragm, we're good. Kind of hit on some of this, but now we're looking at it more from a digesting standpoint. Your mouth, your teeth, your tongue, your gums, that's the starting point, right? You're going to drink, you're going to eat. With the chewing aspect, the mastication, you need to start breaking down the food items into like more manageable items to swallow, to go down the esophagus. You have a release of different enzymes and whatnot, like amylase starts breaking down the food as soon as it's in your mouth. Then it goes down the esophagus into the stomach, where again, bile and stomach juices and acids start breaking down the item even further. Then it goes into the larger intestines to again start being broken down even further. And all while, every point of the way, elements are being extracted. Okay, whether it's vitamins, water, we're trying to extract it. So where at the last point, the only thing left are the waste products.
Backwards, small intestines basically do all that, then they hit the large intestine, and then it just goes out. Large intestine does a little bit, something like that, but it's mainly the small one.
Unless I'm mistaken, because you have the ileum, jejunum, and duodenum.
Yep.
I know, I'll double check. Or someone else double check, so I don't have to do it. That's fine too. It's all good to me. Liver, you got your bile duct, small intestine, large intestine, appendix, rectum. We're still a little unsure on what role the appendix plays in life, but it's still there. Some say it doesn't matter. I think new study says it does matter a lot. I don't know. Then of course at the very end you have your rectum, because again you want to get rid of all the waste products. Anything that is not utilized by the body just gets excreted. Okay, just gets excreted. Enzymes are added to the food. Yep. Salivary gland, stomach, liver, pancreas. Yeah, everything's kind of play around to break down the food items. Food is converted into basic sugars, fatty acids, amino acids. So again, you got your carbs, your fats, and your proteins. Further processed by liver, circulated via blood throughout the body. Perfect. Yeah. I'm just having a go time. Don't mind me. Lymphatic. Who's got the time? Give me a time window. How much time do I got?
206.
2 minutes. 15 minutes sounds good. The lymphatic system. Elements of the lymphatic system: spleen, lymph nodes, lymph vessel, thymus gland. So various glands, sure. It plays a big role in injuries, which we're going to cover when we get to more trauma, because you're going to have a bunch of swelling that occurs when a tissue is injured. A bunch of swelling occurs. Lymph and lymph nodes play a vital role in that aspect as well, and we'll talk about it and how to kind of treat that. Supports the circulatory system and the immune system. Lymph, okay? Lymph is a thin, straw-colored fluid that carries oxygen and nutrients to cells and waste products away. Helps to rid the body of toxins and other harmful materials. So again, it's more of a support role. Moving on to the endocrine system. Again, there's whole chapters on each of these, so don't stress. Complex message and control systems integrates many bodily functions. Hormones are released directly into the bloodstream. Epi, norepi, insulin from the pancreas, which helps you utilize sugars to your cells. We'll get into all that. Again, more glands. Here's like a nice little image of all the glands in the body. The brain controls the release of hormones. Excess or deficiency in hormones can cause different diseases, and we'll do a deep dive into all those different types of diseases. As an EMT, you're going to respond to a lot of different patients that have different disorders, different deficiencies, excess. Most of the time, they're going to be pre-existing conditions, so they're already going to know that they have it because they've, again, usually it's just an exacerbation of their symptoms that causes them to call 911 for the most part, okay, for the most part. The urinary system controls the discharge of certain waste materials, filters through the blood and the kidneys. Nothing really there. It controls fluid balance. Fluid balance is very important. It plays a huge role in your blood pressure, okay? Nothing you can really do as an EMT for it. If you have too much fluid, even if you have too little fluid, your whole purpose of an EMT is to do documentation, okay? Document everything that you see, all your vital signs accurately. If you go the paramedic route, nursing route, doctor route, you'll have a little bit more in your toolbox, so to speak, to actually help with that situation. Ensuring you have a nice pH balance. Again, that's going to have an impact with the metabolic type conditions that you can have with having too much of an acid or a base. And then too much water plays a role in that aspect. Good. Kidneys, urinary bladder, perfect. So there's a little diagram, kidneys, bladder. Your kidneys are going to filter out, again, all the waste products and nutrients. It's going to go into your bladder and then excrete it out. Good. Genital system, again, whole chapter on this as well. Controls reproductive processes. The male system, testicles, epididymis, vasa deferentia, prostate gland, seminal vesicles, the penis. Boom, perfect. There it is. I'm sorry, we'll go really, really quick. Female system, ovaries, fallopian tubes, uterus, cervix, and vagina. You guys are going to learn how to deliver babies. So that's going to be fun. So you're going to learn all about this. Life support, I think we're almost done. Life support chain, all cells. So yeah, all your cells in your body need oxygen. They need nutrients to survive. Okay? If there's a deficiency anywhere in there, that could lead to a systemic issue. Okay? That's a whole widespread body issue. The circulatory system, one of the most impaired. Now, they all matter, right? All your body systems essentially work together to accomplish life. Okay? And not just life, quality of life. So if there's a deficiency anywhere in that system, it could have a lasting impact. If interference, yeah. Perfect. Cells use oxygen to turn nutrients into chemical energy through metabolism. I'm debating if we're going to get deep into that. So talking about aerobic, anaerobic metabolism, talking about glycolysis. I'm leaning towards no, because you are going to do it in paramedic school and nursing school. Basically, it's how does the body take a carbohydrate, break it down, and how does it become energy? You know, your whole adenosine triphosphate kind of doodad. Yeah. It's good. It's good to know, but it's just so much right now. Because it's a one semester class. There is an aerobic and an anaerobic metabolism. So how does your body create energy using oxygen and without using oxygen? Movement of oxygen, waste, and nutrients occur by diffusion. Yep. pH is critical in diffusion. Yeah, sure. Body expands to a large amount of energy and maintain normal pH. Awesome. Oh, I thought we were done. No. Pathophys. Pathophys. Does anybody have the PowerPoint up? If not, it's all good. I just want to know how many slides I got left. It's fine. It's fine. We're doing fine. I got 8 minutes, I think. 101. And how many are there? Not all, just like until the review questions.
Until the review, 108.
Okay, we're almost there. We're almost there. I got this. Pathophys is the study of, again, disease processes and their impact on the body systems. Compromise could have, an effect. Here, respiratory compromise is the inability to body to move gas effectively. Again, you have hypercarbia, hypoxia. Hypoxia is referencing the low oxygen levels. Hypercarbia, excess carbon dioxide or excess waste or excessive waste products, which is the carbon dioxide. Factors that impair ventilations, blocked airway, because again, both ventilation and respiration could impact how a person is actually getting oxygen. So in terms of just impair ventilation, the action of breathing in and out, a blocked airway. So if you have a foreign body airway obstruction, that's going to inhibit your ability to breathe in and breathe out, right? Impairment of the muscles of breathing. So if you have an injury to the diaphragm, you're not going to be able to breathe effectively. Airway obstructed physiologically, such as for asthma. Okay, so that's when your bronchioles, essentially, and bronchi constrict. So they get smaller, so it's harder for air to pass through those passages. Okay, that's fine. Factors that impair respiration, so that's all about the gas exchange. Atmosphere, a little bit. That more has to do if you're not acclimated to a certain elevation. So if we were to go, we're pretty much at sea level, we're a little higher. But if we would go to, Colorado, right? It's much higher. The air is more dispersed. The oxygen molecules are more dispersed. So there's when you take a breath in, you're not getting the same concentration of oxygen as you would here. Okay, so your body needs at least 21 days to acclimate to that environment. Impaired movement of gas across cell membranes. There's a lot of other aspects that kind of play a role in this. There is carbon monoxide poisoning. Which is the other stupid ones? Let me see. That's fine. That's fine. So here's the ventilation perfusion mismatch ratio. So again, this is all about how ventilation and perfusion have to essentially both be operating effectively for adequate oxygenation. If there's one mismatch, so to speak, you're not going to get appropriate oxygenation. Effects of compromise to the body. Again, oxygen levels fall, carbon dioxide levels rise, respiratory rate increases, body becomes more acidic. That's because there's more carbon dioxide because the body can't release it quick enough. The brain sends commands to the body to breathe because, again, that's how a normal breathing drive works. It's all through carbon dioxide levels. Cells move from aerobic to anaerobic. So from using oxygen to create energy versus not oxygen. Okay. Shock. There's a whole chapter on shock. Shock occurs, again, shock is just a state of hypoperfusion. We're going to go ahead and talk about shock in chapter 13, 12? I don't know. One of those chapters. But we're going to talk about the different categories, hypovolemic, cardiogenic, distributive, obstructive, all that fun stuff. Good, and we'll talk about that later too. Okay, and I told you you're not going to talk about metabolism. Okay, we're fine. Okay, we're good. We're fine. We're fine. It's all good, guys. It's all good. It's all good. Don't even worry about it. Don't even worry about it. Okay, team. Real quick, got like 10 more minutes, I think. So let's just hang tight. Let's have a little chit chat. So this week 2, you guys are chugging along. Make sure you're staying on top of your studying. Okay. Above all else, your reading is the most important aspect because again, in the medical field, there's so much information to be had. Okay. I could sit up here for again 6-7 hours and only talk about one chapter, and it's still not everything in that chapter. It's wild, okay? So take the time, read those chapters, go through your studying, make those flashcards, and then make sure your homework's all set and all that fun stuff. If you have any questions, go ahead and just shoot me an email. I promise I'll respond eventually. eventually. I will be on campus a little late tomorrow to my office hours. I got to take my my daughter to the doctor's appointment, but then I'll be here. Thursday's group, Ed won't be there until later on, so it should just be shot for a bit, and then I'll dive on in there. Any questions? All right, team. Class dismissed. Get on there.
I didn't throw it out.
Stop taking notes.
20 per chapter.